Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Ayman, for your nice and important introduction. Now, a great honor to start our scientific program, first session. I am happy because our first speaker, the eminent Dr. Munier Nazzal, he will talk to us about pedal approach for chronic limb-threatening ischemia.
Professor Munier Nazzal is the head of the vascular unit in Toledo University in the United States, and he's very well into research of peripheral arterial disease, and we are really delighted and privileged that he will honor us with this lecture. Thank you.
Thank you very much, Omar. Thank you very much, everybody. And I'd like to thank the organizing committee for the invitation. And I'd like also to thank my partners in the Pan-Arab Vascular Surgical Society, especially my teacher and my mentor, Jamal Huballah. He's my teacher, by the way. I mean it. He was my program director and teacher when I was a fellow. So this is a subject I'm going to talk about as and I think that as all vascular surgeons should adopt and not to be left actually out of our set of procedures, which is the pedal approach or the distal approach. I have no disclosure. First, we know there are challenges to distal bypass surgery. The main challenge is the availability of the conduit, which is the vein, especially a gray saphenous vein. And also you have to have a very good inflow and outflow. And in diabetic patients, you have to have also an inline flow to the area where the ulcer is. There are technical factors other than the expertise of the surgeon that had to be taken in consideration. And we know the larger the vein, the greater saphenous vein, and other inflow conduits will make a difference for patients with chronic limb ischemia, especially those who have diabetes. Sometimes we do a very good bypass and still the patient is not healing in about 18% of the cases, and the wound healing might be either not happening or very slow in spite of a good bypass. And the median ulcer healing sometimes takes up to 6 months to heal. So I'm not saying open surgery is bad. I'm saying open surgery does not fit every patient. The problem with open surgery, usually you do it to one artery, from an inflow to an outflow, and usually you choose the best artery, and sometimes we choose the artery to the area. The endovascular approach in general has the advantage that you can open multiple vessels to supply the area. And we all know the two studies, the BEST study and the other study, which is the basal study, both of them almost having conflicting result. The BEST study, they say in the presence of a good conduit, you should do surgery. The basal study says the endovascular approach should be first and it has better results. So open versus endovascular is something very common. And this is the approach to endovascular, which is the regular retrograde approach. And this is the open surgery. Just if you show this to a patient, that's enough to deter the patient from accepting the procedure. And we all know the angiosome theory. It is still a theory. It's more accepted for some surgeons and plastic surgeons more than other surgeons. But you have to supply the area that has the ulcer with the blood in general. And we know that if you bring blood to more than one vessel or to the area supplied by the angiosome, the chance of healing is much better. And we know the theory that all the vessels are connected together in the foot. But we know also from other evidence that in diabetic patients and patients who have end-stage renal disease, the choking vessels that connect the different arteries, they don't work. So if you supply one area from a bypass, doesn't mean that you are opening the blood flow to all areas, especially diabetes and end-stage renal disease. So result of distal endovascular revascularization is very common actually. The endovascular therapy, not the open therapy, offers the potential for angiosome. So this is the first advantage of the distal approach. Healing of an ulcer also is much better if you do angiosome revascularization. We are comparing 9% to 38%. Why do we have to learn the retrograde approach? Because in 20% of the cases, really, there is not a good blood flow, or you cannot go antegrade. And the retrograde axis sometimes provide a better flow. So the antegrade endo is not always possible, which is the common way of doing endovascular. It fails in about 20 to 25% to cross a lesion, especially femoropopliteal area. It requires a re-entry device with its complication, and it is a higher stent use and a higher cost in general. So it's why we have to do the distal approach. Where we can do the distal approach, anything below the knee is a place that you can go for a distal approach. The more distal the disease, the more distal you have to go to open to try to revascularize the vessels. And in one of the studies actually that was published recently, the number of stents used, the use of the stent, the complications and the patency was higher actually with the distal approach than the antegrade approach. Was better with the distal approach than the antegrade approach. And this is like you see on the left side, the image here where the approach in the anterior tibial artery, you can do multiple vessels through this approach. You can achieve a better healing, and the duration and patency is better if you go distal approach rather than the antegrade approach. You can actually, even from a distal approach like you see here, you can do 2 vessels, even if you go distally in those areas. The problem with endo in general, that there is less patency and the same limb salvage, but better healing, more re-intervention, but it is very less expensive. This is an example of multiple outflow vessels. The pedal approach in general, the success rate up to 80%, and honestly the success rate is more related to the ultrasound use and opening and entering the vessel in general. Generally it is less costly, and primary anesthesia patency is about 80%, but there are requirements. Not everybody should do it, number one, and not every situation should be used. You need a very good ultrasound, you need a skilled use of the ultrasound, you need to have time, you need to plan very well, you need multiple devices, not only a balloon or a wire, and you need a very good radiation protection. The ultrasound, you should have a high frequency needle optimization, scan by the operator. Don't call the ultrasound tech or another person to scan for you. You have to do it at the same time to learn how to do it together. Evaluate the best vessel to use, and you can do that only if you evaluate all the arteries before you start the procedure. The planning is very important, like you see here. Sometimes you might have to go on both proximal and distal in order to snare the vessel and the wire, to snare the wire to be able to do the procedure. And sometimes actually you can do a procedure from both sides. Once you have the distal and the antegrade approach together, that will give you a better strength and a better access to many of those vessels. This is an example, actually, a 67-year-old female patient who came with what you see, gangrene almost, and we tried to access the antegrade approach to revascularize it. All the vessels were so calcified.
1 minute more for Dr. Munier, please.
So were calcified, and we managed actually under ultrasound to go distally in the patient. As you can see here, no need to go through the films, but the distal approach, we managed to do both legs from one side We opened the calcified vessels from inside the vessel because we know we could not access them in the groin, and we managed actually to open the vessel. We did it in this patient. This is the end result. She had no blood flow at all. You see the distal, SFA, popliteal, and the actually arteries are all open. So in general, distal approach should be part of the management for any vascular surgeon. It should be used either the only procedure or in combination with other procedure for Petter's limb salvage. And thank you very much for the opportunity.